When I was in BDS, it was very frustrating to take the final impression in complete denture fabrication. There will be no retention or stability and the patient will come back complaining of loosening of the denture. Even during my post-graduation, I faced many difficulties in making a proper final impression. But then I studied the literature and followed some steps, and my border molding and final impression improved dramatically. In this video, I want to share the tips so that you can have a good final impression and a happy patient every time. In this video, we will mainly talk about the mandibular final impression. So let's get started. First, we have to talk about the custom tray. Your custom tray is very important because most of the time our custom trays are overextended. So it must be 2 mm shorter than the borders in the primary cast. We will check the extension in the patient also. In the mandibular impression, 2 additional handles on each side should be placed on the first molar region. Why? Because most of the time we displace the soft tissue in the posterior mandibular region with our fingers while placing the tray and border molding. The posterior handle are used as a finger rest to complete the tray placement and stabilize the tray in the correct position with minimal distortion in the soft tissues. Now let's talk about the procedure. You must have heard the phrase, a dentist should make the impression instead of taking the impression. What does that mean? See, whenever we are making something, first of all, we have to have some idea of what are we making. We can't make anything without knowing it. The impression should be in your head before it is in your hand. You should know what the lingual sulcus will look like, how the alveolingual sulcus look like, how will be the labial frenum, retromolar pad area. Everything you should have in your mind before you take the impression. So how to do that? We have to observe the oral cavity of the patient, retract the cheek and carefully observe the limit of the labial sulcus and the buccal shelf area. Retract the lips to see the extent of the labial notch. Similarly, feel the depth of the lingual sulcus with your fingers. You will get some idea. Now place the custom tray in the oral cavity and observe the extension. Is your custom tray lifting while patient protrude his tongue? Your lingual flange is overextended posteriorly. Is lifting when you pull the cheeks, your buccal flanges are overextended. Ask the patient to touch the tongue to the upper lip. If it lifts, your lingual flange is overextended. If gets lifted when patient opens mouth wide, the retromolar pad area is overextended. Trim all these area. You will be surprised to see how much overextended trays we make. Now start the border molding. Get proper hot water and a burner. Start with a lingual flange. To record the lingual flange, we first have to understand the anatomy of the lingual flange. The lingual flange can be considered in 3 regions: anterior, middle and posterior. Anterior region extends from the lingual frenum back to where the mylohyoid ridge curves above the level of the sulcus. Here a depression, a mylohyoid fossa can be palpated and corresponding prominence, the mylohyoid eminence, can be seen on the impression. The lingual border of the impression in this anterior region should extend down to contact with the mucous membrane floor of the mouth when the tip of the tongue touches the upper incisor. The lingual flange will be shorter anteriorly than posteriorly. At the pre-mylohyoid fossa, the flange becomes larger as it extends below the level of the mylohyoid ridge. Second area is the middle region. This part extends from the pre-mylohyoid fossa to the distal end of the mylohyoid ridge, curving medially from the body of the mandible. This curvature is caused by the mylohyoid ridge's prominence and the mylohyoid muscles action. When middle of the lingual flange is made to slope toward the tongue, it can extend below the level of the mylohyoid ridge. In this way, the tongue rests on the top of the flange and aids in the stabilization of lower denture on the residual ridge. In posterior region, here the flange passes into the retromylohyoid fossa. As it does, it is not longer influenced by the extent of the mylohyoid muscle, and so the flange can turn laterally toward the ramus to feel the fossa and complete typical S shape of the correctly shaped lingual flange. Then do border molding of the labial and buccal sulcus by downward, outward and upward movements. For the retromolar pad area, the tray should cover the half of the retromolar pad and it should not extend beyond the pad. Ask the patient to close the mouth with your finger resisting the movement. This will record the pterygomandibular raphe. Your border molding is done. Clean the tray, dry it. Now mix the zinc oxide eugenol impression paste and load it to the tray extending to the borders. Place the tray in the patient's mouth. Don't press too much. Don't start border molding right away. Let it set to moldable state. Start molding. Repeat the movements. Let it set. Remove the tray by breaking the suction and lifting the cheek. Observe the impression for any discrepancy. If bubble exists, load a little material and repeat the process. This was all about the mandibular final impression. So I hope this video will be helpful to you. If you have any query or doubts, let me know in the comment section. Thank you.